Hi, everyone. Thank you for tuning in to McDougall's Medicine with Dr. John and Mary McDougall. I'm their daughter and your host, Heather McDougall. It's been a bit. Happy New Year. It's really nice to be connecting with you all. Let's see. I'm going to say hi. Let me turn this off. Hi to you, Mom and Dad, Dr. McDougall and Mary. How are you?
Well, we're
good.
okay. We're doing fine.
We're kind of getting over the Christmas holidays and the holiday rush, and kind of everything's getting kind of back to normal now.
Got the tree down. We didn't have to recover from any debauchery, though, like I imagine a lot of people did. I know you partied, you had fun, but we just relaxed and enjoyed our mashed potatoes and fruit drinks. Oh, well.
Well, I can't believe we're already a week into the new year. Lots is happening. I know there's some things that you want to talk about tonight, Dad, before we get started.
I try and make the first few minutes relevant to what's going on and questions people have to answer, or science. You know, I'm thinking of titling this section called "The Truth Don't Change." You know, why do I keep saying the same thing? It's because the truth don't change. And so, a topic came up this week. And what I wanted to do is talk to you about that topic a bit and see whether we get the show going without any trouble. All right, in the news, Defense Secretary Lloyd Austin. It was a mystery for a few days as to what the elective procedure was that he went in for prior to his ICU visit, which has lasted, I think, 4 or 5 days. He went in for an elective procedure, and that was following a prostatectomy on December 22nd, 2023, and then he went in for last Friday.
Did he have a prostatectomy?
He had a prostatectomy.
Oh, okay.
Yeah, and then he went in for the urinary tract infection after his prostatectomy. So I get a chance to talk to you about prostate cancer, PSAs. I'm not going to talk to you much about urinary tract infections, and that's what we're going to talk about. One of the reasons that Lloyd Austin may not have said much is because he's described as notoriously private. But he did tell everybody today, June 9th, 2024. So the word is out, and that's the subject I picked for tonight to talk to you folks about. Prostate cancer. It's the second leading cancer death in the United States and worldwide. In fact, some people say lung cancer is second after breast cancer in some populations, but in other worldwide, basically prostate cancer is the second most common cancer. And you see the incidence, you see the map here I put of various parts of the world where prostate cancer is common, in the darker blue areas. Well, do you see any relevance to the economic wealth of the people in these particular areas in the dark blue? Do you have any idea what these people eat? In Brazil and Argentina used to be the biggest consumer of beef in the world. They had the highest incidence of colon cancer in Brazil and Argentina in the world. Europe, Australia. Do you see the pattern? Rich foods give you prostate cancer. So in the US, there are 288,000 new cases and 34,700 deaths. That's a lot of difference. That's like 1 in 10 people die who get it, right? In other words, 9 out of 10 could have been spared even finding out that they had it. I think so. All right, so this is the mistake that I would guess most of our listeners are making, and unfortunately, most of my colleagues still don't have this understanding of cancer within their grasp. They just don't get it. So they don't know why patients don't do well. They don't know why early detection tests don't work. Why we have limited benefits when it comes to cancer. Anyway, mastectomies don't work. Prostatectomies don't. We're going to get into that. The reason is that people believe the following. They believe a cancer starts as a little area in particular one organ, breast, prostate, colon, etc. It starts as a single cell, and then it grows in that particular tissue. And it keeps growing and growing and growing, and finally gets really big. Well, maybe not that big, but maybe that would be big enough. And when it gets bigger, then it metastasizes. And it doesn't metastasize throughout the body first. It goes to the lymph nodes first. And then past the lymph nodes, it goes to the rest of the body. And this is why, most surgeries are attached with an extra surgery, which is to remove the lymph nodes, is because doctors, not a scientist, not any people who understand what's going on, they understand there's a centripetal event that goes on where they believe it's in stages, little cancer, big cancer, spread to lymph nodes, then spread to the rest of the body.
I can't believe it. I mean, it's like it's been like 100 years.
They've known this for at least 80 years. I've been talking about it for 45.
I know. And everything else, well, no, it doesn't seem like everything else is catching up. I think of a few things that are catching up.
People
but
believe in logical things. This is logical.
it is.
And
You're
besides
right.
that,
It is logical.
it fits into the way that they've been treated. We take the breast or colon cancer out, prostate cancer out, then we take the lymph nodes around it, because that's our second area of defense, where we stop that cancer, the lymph nodes, and then to the rest of the body. But that's not the way it happens. The way it happens is this. A cancer begins. Let's just talk about prostate. We could be talking about breast. We have under many circumstances, but this could be colon cancer, prostate cancer, lung cancer, any solid tumor. It starts as a single cell that gets injured. And most cells are not allowed to double anytime they want. But once a cell gets injured, it loses this neighborliness, this friendliness, and it starts dividing in its own free will. Now, cells are allowed to divide, say, when you're growing as a child, or say you cut yourself, you have a wound, the cells can replicate and close the wound. Otherwise, if your cells were allowed to divide at their own free will, you'd be a misshapen lump in a matter of hours. So it's not allowed unless they get injured. And then they start dividing at their own free will. So let's begin with cancer cell begins. It divides at a regular rate on average of every 100 days. So in 200 days, you got 4 cells. A year later, you got 8 to 12 cells. A prostate contains 100 billion cells per prostate. And then you go to 64, you've got 2 years of growth. A tumor less than 100 cells lurking in a mass that contains 100 billion cells. You can find that with a team of pathologists. All right. Divisions continue. 2 years, it's not detectable. Finally, it gets to be a 6-year-old disease, and you start to maybe find it then. It's a millimeter in size. It contains 1 million cells. All right, and as I didn't say 100 billion, I meant 1 billion. You can finally detect it at 1 billion cells in growth, which is 1 centimeter in size. It's about the size of an eraser. That's when the doctor can feel it on a prostate exam. That's what you can find out on these imaging techniques. The tumor is about the size of a small marble, an eraser of a pencil. It has to grow to that size, taking 10 years on average before it gets big enough, 1 centimeter, 1 billion cells, before it gets big enough to elevate what we call the prostate-specific antigen, which is a blood test used to diagnose prostate. It's been growing for 10 years. On average. And doctors don't feel it until it's at least 10 years old on average. Except no tests find it on average until it's 10 years old. By that time, it's spread. How is it spread? It's broken off into the venous system, the veins. It spreads to the liver, the lungs, the bones, the brain, etc. Now, yes, it does go to the lymph nodes, but that's incidental. Okay, these lymph nodes are there to protect you. They fight against the cancer, yet doctors are so busy taking them out. This is your defense mechanism, these lymph nodes. And it does not spread from the tumor to the lymph nodes and then to the rest of the body through the veins. It goes from the tumor into the veins to the rest of the body. Okay, now don't forget that it takes 1 centimeter in size to elevate the PSA level. That's the blood test. That takes 10 years on average. All right. So we have this test called a PSA, prostate-specific antigen. It means it's a protein that is derived from the prostate gland that gets elevated when the prostate gland gets inflamed, irritated, or when it develops prostate cancer. Now, as men,
Excuse me, that's a blood test?
blood test, yeah, little blood test.
Okay.
Right? So you have all these screening programs. Doctors are out there telling you, you're a bad person if you don't get your PSA tested. Everybody's got to get their PSA. But not so much lately, because the medical profession has come to realize what the truth is of this testing and treatment, which you're going to learn about today. If you randomly select men off the street and you get a blood test on them, 10% will be positive for PSA. So you got a 1 in 10 chance. If you allow somebody to have your blood, a 1 in 10 chance of having an elevated PSA. And then you're told to have a biopsy. It's not a biopsy, it's 12 needles that are stuck through your rectum into your prostate gland. And in the process, they injure the nerves of the prostate. We'll talk about that in a minute. Okay, so 10% of men are going to be found randomly picked off the street. Of those who have a positive PSA, about 30%, depending on their age, are going to be found to have prostate cancer. Whoa. Depending on the age, 8% of men in their 20s have a positive PSA for prostate, or positive biopsy, excuse me, for prostate cancer. 30% of men in their 30s have a positive biopsy. 50% of men in their 50s. And men my age, it's almost 100% have prostate cancer on biopsy. But that's on biopsy. You can have cell changes occur in the prostate without it going on to metastasize. And that's what happens in most cases. Or it's so late in its metastasis process, it's spread, that you die of something else first. Okay, what happened to, let's see if I got everything I want to tell you. Oh, as far as this, one other thing you got to know about this PSA testing. I told you they stick 12 needles in your prostate through your rectum. Gentlemen.
This is the biopsy. This is not the PSA test.
This is a biopsy, right?
Yeah, okay.
Okay, now keep me on track.
All right.
This is a biopsy right here. Okay, so I told you that 30% of men with a positive PSA, which is 10% of men, on average, are going to have a positive biopsy based on the needle biopsy. But the needle biopsy is 12 needles stick in your prostate gland. Yeah. This damages the prostate gland through which the nerves that control your erectile dysfunction pass. Erectile function pass. The nerves that control your erectile function, that's your penis. They get injured. 41% of men report erectile dysfunction 1 month after surgery. And for 15%, it becomes permanent just from the biopsy.
Really?
Yeah. Man, about half of men experience pain during the biopsy. It's not fun. I've never had one, but I hear it's not fun. Okay. Lloyd Austin, his complication.
Yeah, okay.
All right. Got it right, Secretary of Defense?
Yeah.
All right. Lloyd Austin, he had his prostatectomy done in late December, got in trouble last Friday, which was, today is the 9th.
Today's the 9th.
Yeah, so it was probably like
I
the
think
6th.
he went into the hospital though on like the 1st of January. It was like a week after he came home from.
Well, he was in there 4 days and he wouldn't tell anybody because he was a private person about his diet. And today it came out. Anyway, he got an infection. The most common complication of a prostatectomy is an infection. So, no big deal here. It just happened, and it happened to him, and he didn't want the public to know about it for whatever reasons. All right. So you've got this problem of erectile dysfunction, which this is This is the period of erectile dysfunction. Somewhere between 10 and 82% of men who have their prostate removed by surgery, which is what Mr. Austin had done. Somewhere between 10 and 82% of men who go through this radical operation can't get an erection anymore in the rest of their life. Okay? But the important thing for you to understand is there's no difference in survival between doing nothing, which is called watchful waiting and doing radical treatments such as radical prostatectomy and or radiation. You don't live any longer. And why don't you live any longer? Because by the time you detect it by PSA or by feeling on a rectal exam or any other test, it's 10 years old. It's already spread, if it's going to spread. Now, remember, most of the cases don't spread. It's only a few of them that spread. Okay, so watchful waiting is the preferred technique. I recommend that to all my patients.
Oh,
Well,
my dad had it for 30 years or more.
Your dad, well, yeah, for a long time he did. Well, I could tell that story if I have time.
Okay.
Anyway, what I recommend is, first of all, men do not get a PSA test. You have a 10% chance of being a cancer victim. And then don't go on and get a biopsy. You have, depending on your age, you're my age, you have 90 to 100% of you being told you have cancer. Don't do it. And then when it comes to the next phase of treatment, don't subject yourself to radical treatments that leave you impotent and scarred and bowel obstructions and all kinds of garbage. Don't do it. There's no survival benefit. Will your doctor tell you this? Yes, he or she will, because it's so well known what I just told you that none of them would dare look you in the eye and tell you otherwise.
Really?
Oh, yeah. All right. So what else should you do, regardless of whether your PSA is positive or negative, or whether you're diagnosed as having prostate cancer or not? The American Cancer Society came out in February 13th of 2015 and said that after you're diagnosed with cancer, breast, colon, prostate, melanoma, you need to change your diet. You see what they say? Prudent diets based on fruits and vegetables and unrefined grains. Do you see that there? And not to eat the Western diet with the meat, processed foods, and the fats. Do you see that? That's our American Cancer Society official. How many doctors recommend to their patients after being diagnosed with having breast, colon, or prostate cancer that they ought to stop throwing gasoline on a fire? Makes no sense. Anyway, so fat is the dominant factor. If you had to say one thing, you'd say fat is what not only initiates, but also promotes the development of these cancers. They grow faster on a high-fat diet, you die sooner, et cetera. And that's why the American Cancer Society tells you to eat a low-fat diet. But, it's not just the meat. It's just not the processed meats that they keep talking about. They tell you that the prostate cancer, breast cancer, colon cancer are caused by red meat. And especially processed meat. You go, oh, I only eat chicken and turkey and ham. Well, excuse me, that's red meat. And it doesn't matter whether it's processed or not. That's meat. A muscle is a muscle is a muscle. Maybe not be as red as you like, but once upon a time it was bloody red. Anyway, so that's what you do. And that's what I wanted to tell you about. So next time you hear a news report about our Secretary of Defense, Lloyd Austin, you'll be better prepared to understand what he went through. Okay. Let's see. Do you see a stop? There we go. Thank you, Ed. There we go.
All right.
Oh, I need to have you on the screen, Heather.
34%, 34%.
Okay, let's get to some questions.
Okay, you're not on the screen for us.
I know I'm working on my camera. I don't know what's going on.
Okay.
Well, you have to there you go.
Not ideal, but that'll work. Okay.
Yeah,
This question is from Sharon. She wrote in, she's been diagnosed with a slightly enlarged aortic valve, and she wanted to know if diet can reduce the size or if she needs to get surgery.
I'd be surprised if diet reduced the size. It will a little bit in the sense that when you change your diet, you take the workload off the heart. And in that way, because of less work on the bulb of the aorta, it may see a tiny bit of shrinkage in size, but nothing to correct any real organic problems, some real disease. You're not going to correct it by diet. The disease of the aorta, the aortic valves, the aortic bulb, These are diseases that are caused by the Western diet. I mean, I can show you. I can go right to the research. You can go do yourself. You can look up aortic valve disease and Western diet or saturated fat or American diet. You'll find that that's what people believe. You know, the circulation, the blood vessels that go to the valve and to the bulb and the rest of the aorta, they get compromised. And, you know, as a result, they swell, et cetera. Do you need surgery? Well, you need surgery when you need surgery. And what I would do is I'd get a couple of good specialists and I would ask them when I needed surgery, and I would work one against the other to see whether or not you get the answer you want. And ask the doctors why you recommend it early or late, et cetera. Generally, this type of surgery, valve surgery, is not done until the person is compromised, seriously compromised. And then the way to do the surgery is they do a trans aorta. They stick it through the femoral leg artery, up through your aorta, and they take this valve and they put this new valve in. Now, I don't know whether they would do that with a bulb or not, an aortic bulb, but it's amazing technology. I mean, it's just almost outpatient, not really.
How can they tell when it is
right spot?
severely enough compromised that they need the surgery?
It's when the person says, I can't take it anymore. Or they probably have some percentages worked out too, Mary.
Oh, okay.
You know, ejection fraction percentages, you know, they're decreased to a certain point. We've decided that's what, but it's basically when, you know, because they throw the old disease valve away and they put a new one in. You know, it's not like you're preserving anything.
Yeah.
So.
And the new one works. They work quite well.
Yeah, they're made of cow and pig valves. So, you know, you're not quite a vegan when you have one of those. but they're much better than the old valves. I used to start out when I was in my early training. We would use a Starling valve, which is a ball and basket. And the heart would pump and this metal ball would go up in the basket, let the blood out to the rest of the body, then fall back down when the heart relaxed. And you'd hear this.
Yeah, I remember the noise.
Anyway, we don't do that anymore. We take animal valves and use them, cows and pig valves. So when you need it, when you ask the doctor, you know, there is a time when you'll end up having more good done for you than harm. But you need to ask that question. I would ask at least a couple of specialists, because this surgery is a big deal. And ask if there are alternatives. Like, you know, right now, if many doctors are still doing the open heart, where they split the sternum open. You go on the heart lung machine. That's a big deal. And whereas other ones do this trans aorta valvular replacement, which, you know, is a lot less of a complication problem.
Well, it seems, couldn't they do it with like one of the laparoscopy things? It seems like they ought to be able to just cut it. Yeah.
Maybe
cut
someday.
A little hole and
Maybe
just
someday.
do it that way. Yeah, that would be a lot easier.
You know, some of the things that are going on in medicine now are really Star
Wow.
Wars. I wish they would translate into a better, longer life for people. They're real fancy. I mean, good grief, the technology we have would impress anybody. You take pictures of the body that looks just like you're holding the body in your hands. We've got such detail, but it doesn't translate into what you care about, which is having a better, longer life. It's interesting. Just like these days, they do all kinds of special techniques to radiate the prostate. You know, they do localized beams and so on, so they don't damage a lot of surrounding tissue. No improvement in survival using that technique. Why? You know why. The reason is it's 10 years old by the time you found it. And if it's truly prostate cancer or breast or colon, it's spread throughout the rest of the body. If it's not truly prostate cancer, or it's not a prostate cancer or breast cancer or colon cancer that would have affected you during your lifetime, then if it's diagnosed, you've been overdiagnosed. That's what overdiagnosis is called. You've been diagnosed with a disease that would have never bothered you if they wouldn't have been busy looking for it, which is what, you know, when 3% of this death rate from, I had one of the slides, death rate from prostate cancer per 100,000 people is just a few.
Yeah, I saw that.
Yeah, you see that? I forget what the number was like. Anyway, compared to the number that are diagnosed, which is somewhere between
It was
30 and 80%,
yeah, there was like 300,000
100,000.
were diagnosed and only 27,000 died or something.
Well, something like that. It's a lot less than that. Yeah, I know. There were supposed to just get put up there for you. But anyway, well, go ahead, Heather.
Thank you. Okay, next question. This is from I believe a mother, a new mother. She's wondering what to do if you can't breastfeed. What do you recommend?
Well, that's been a hard one. And it was even in our family. You know, we have 7 grandchildren. And you know, we encourage breastfeeding, of course, in all the kids, but in one case it didn't work out too well. And so I was put in a position of trying to decide what to feed my nephews because mom couldn't breastfeed for a whole bunch of real reasons. So what was I going to do? You know, I thought about the different options for my grandboys. What am I going to do? And one of the things I thought about was getting a surrogate mother, because that's what they used to do. I mean, think about it. If you couldn't breastfeed your child, you know, 100 years ago, you know, or 1,000 years ago, what would you do? You wouldn't let the child starve to death. What would you do? You'd hand it to your sister or to your best girlfriend.
Or someone else.
Yeah,
that
someone
just
else
had-
lactating. Yeah. But in our society, that's considered close to pornography to do that. You know, we're socially screwed up. That would be something not tolerated in our society. But anyway, that's what you would ideally do. The second choice was a milk bank where they collect milk. Women donate their milk, they get paid for it. But there are women who eat the American diet, the Western diet. So I knew I didn't want my grandsons to have that food because it's so heavily contaminated with environmental chemicals. A woman loses half her pesticide load into her breast milk within 6 months of breastfeeding. I didn't want eating the Western diet full of all these chemicals. I didn't want this mother to feed my grandkids. All right, what are you going to do? Well, it came down to there's something called hypoallergenic denatured protein cow's milk formula. It's for kids that are allergic to cow protein, which a lot of them are. You're not allowed to sell it in most countries. In New Zealand, I think it's illegal. In the US, it's legal. You can buy it on the groceries and the, you know, denatured cow's
You
milk.
can't buy it
You
at
can't buy it
all.
in New Zealand. No, it's
Not
illegal.
even with a prescription.
Maybe with a prescription you can,
Oh,
but not over the counter.
okay.
Anyway, some people are really concerned about feeding this hypoallergenic formula, but it was the best choice I could figure because what they did is they took cow's milk and then they broke up the proteins, you know, the beta casein, et cetera, milk proteins. They broke it up into individual amino acids so that the children wouldn't get allergic reactions such as, you know, multiple sclerosis or rheumatoid arthritis or, you know, all kinds of allergic problems due to dairy. And there are a lot of autoimmune diseases and things that be classified more as allergies than autoimmune diseases. So anyway, denaturing the protein takes care of that. Now, we ran into another problem, and that is that babies wouldn't drink the denatured protein milk. They really had a hard time taking it in. So what we did is we looked at the packages of the denatured formula and the regular formula made by the same company. And what they did is they put sugar in the regular formula. So what we did is put a little sugar in the denatured protein mixture that we fed the babies. And as time went on, we reduced the sugar in the formula. Otherwise, the kids wouldn't eat it. That's how they get to eat. The kids, human breast milk is like, it's like 30% sugar. That's why the kids like it, because it got tip of the tongue taste with sugar. Anyway, that's what I would do is I'd get denatured hypoallergenic formula. I would use that. I would, if you don't have a sister or girlfriend that's in a condition you trust her. If she was a vegan for many years and had a clean body, I'd trust her. But you know, where are you going to find one of those?
It was pretty hard in the middle of the night too.
Well, yeah, but you could put it in a bottle. I think you do that. Yeah.
Yeah, you could.
Have her
you.
move in. I bet in the old days they used to do that.
I'm sure.
I'm sure back in the old days, and we could go into all kinds of stories. They had a whole bunch of people who worked for them
Yeah.
and that fed their babies, don't you think? I'm not going to go into those stories, but I know some of them.
No formula back then. Okay, next question. This is from Peter, and he would like for you to go into a bit more detail about type 1.5 diabetics and how to manage their insulin. And I know you recommend long-acting insulin. If that's not working, would you then go to short-acting insulin?
Okay, well, there's type 1, where there's no insulin produced by the pancreas, or very little, not enough to sustain life. So that's type 1. And then there's type 2, where the body makes loads of insulin, often twice as much insulin as a normal person. But the insulin doesn't work because of insulin resistance at the cellular level. All right, so a type 2 diabetic has all this cellular resistance. Type 1 has a lack of production of insulin. Type 2, a resistance to insulin. There's something in between. And that spectrum is 1.5 diabetes. In other words, you make enough insulin to stay out of the hospital, but not enough insulin to keep you from losing weight or urinating a lot or developing excessive thirst. And so to take care of somebody who has type 1.5 diabetes, if they truly are making insulin, remember a type 1 has to have insulin, absolutely necessary. But what you do is you manage the symptoms. And so you give a little shot of Lantus at night, which is the long-acting insulin, 5 units, 10 units, maybe 15 units. You ask, what if it doesn't work out? Again, you're not trying to make the blood sugar normal. If that's what you're trying to do, you're going to be frustrated and angry and confused because it never gets to be normal. All right? You can chase that blood sugar around with pills and shots all day long, and it won't turn normal. Now, if what you're trying to do is control symptoms like weight loss, which is a sign, or excessive urination, which could be a sign, or excessive thirst. You see, signs are things you observe. Symptoms are things that you feel. All right, so if you get it, if you're treating the symptoms, treat them. We used to go in as an internal medicine resident. Part of my job was we'd take type 2 diabetics, hospitalize them. We would connect them to an IV with we could administer insulin, and also insulin would give the insulin through the skin, and we could take blood out. So we would get a blood test every couple hours, and I would leave for the nurses on the floor a sliding scale. If the blood sugar was, I don't know, 250, you give 10 units of insulin, short acting. Blood sugar, it was a sliding scale. Or that you could check the urine. Okay. And it was +1, +2, +3, +4. I'd say, well, for +1, give 5 units of insulin. +2, give 10. +3, you get it? Okay. I used to watch these people all day long. Their blood sugars went to 350, 50, 250, 175, 160. They never became normal, and they never will. So I don't know what you're trying to accomplish, but symptom control is what you want to do. Making the blood sugar ideal is actually a misguided effort. There are 6 studies done, and I show you those in the diabetes talk that I give on YouTube. There are only 6 done where they aggressively treated diabetics. One was a type 1 diabetic study, the DCCT study, British study, UK study. Okay, that was on type 1. The rest were on type 2. In the Accord, they had to stop the study because the people were dying 17 months early when those people were treated aggressively to try and make their hemoglobin A1C normal at 6%. That group that was aggressively treated, 4 shots of insulin a day, 4 tests a day, 4 different kinds of pills a day, they had a higher death rate from heart disease such that the National Heart, Lung, and Blood Institute asked the investigators to stop the study 17 months early. The advanced study, no benefit. The veteran study tripled the risk of sudden death. You don't want to make your blood sugar normal or your hemoglobin A1C normal. You want to make it right with a type 2 diabetic, or you get off all the insulin. Type 2s get off all their insulin. You don't have to worry about that once you lose the weight. Type 1.5, you want to control symptoms. Type 1, you want to control symptoms and give enough insulin. I don't know. You know, like, all I can say is don't make your sugar too low if you're a type 1 diabetic. The recommendation for children, because they have a high tendency to have low sugar reactions because they're kids. They run around. They don't eat all their food. So they have a frequent episode of low sugar reactions, which are deadly and dangerous. The standard recommendation is to not let the fasting sugar go below 150. Normal's 100 for a normal person. Don't treat it to make it lower than 150 because you'll cause them to be hypoglycemia. And I would give the same recommendations for adults. You're better off, much better off, to undertreat than overtreat. Less is more. Overtreatment results in hypoglycemia, which you could die from. You could suffer brain damage from. You could get picked up by a police officer for driving under the influence of something, intoxicants, DIU. You could get in an accident and kill people. Don't overtreat. All right. Hypoglycemia is dangerous.
I shared your video on diabetes in the chat too, so you can check that out if you want to learn more.
Yeah, I hope you folks are going to my YouTube talks. I put them up there for you. It's basically all I know. So
spend hours there.
Truth don't change. We're gonna have a nice session next week because if it wasn't for Lloyd Austin, I'd have had a whole bunch of the Truth Don't Changes articles out for you. But I'll wait till next
they'll
week.
have to tune in on Sunday, right?
Yeah.
We'll have a great show then. Okay, next question. This is from Chicken Charlie. They would like you to explain the process of high blood pressure and how to lower it without medication.
Okay. Now, high blood pressure goes up for 3 reasons. Blood pressure goes up for 3 reasons. One is if you get excited or you drop a bowling ball on your foot, then your pressure goes up. That's due to rapid beating of the heart because of your circumstance. The other way that blood pressure could go up if you increase the volume in the system, more fluid, and you do that with salt. But the real reason and the real consequences of the blood pressure going up come as a consequence of increased peripheral resistance. Think about that. Peripheral resistance, that means peripheral to my heart. That means the blood vessels, the arterioles, the arteries. Okay? What you have is a resistance to flow. The heart can't pump the blood into this bed, which consists of 60,000 miles of blood vessels. It can't pump the blood efficiently because the system's all clogged up.
Tell them about the hose thing. I love the hose.
All right, well, it's like when you want to water a plant 20 feet away, what do? You don't walk over there, put your thumb over the end of the hose. Yeah, right. Pressure goes up, right? Okay. So you're putting your thumb over all the ends of your hoses. You do that with the Western diet. I've showed many of you the blood sludging that occurs. When you eat a typical high-fat American diet, the blood cells all stick together. The oxygen tension in the blood drops somewhere between 5% and 20%. But when you eat the Western diet, the foods, particularly LDL components, bad cholesterol, cause arterioles to spasm. When you eat the Western diet, you make blockages. They're called plaques or hard fiber scars. They cause peripheral resistance. And because your tissues need nutrients and oxygen, the body has to compensate. And there's only one way to compensate. Raise the blood pressure. So what do? You remove the peripheral resistance. And that's what you do with a good diet. And also low sodium does that too. Does being excited damage your arteries or raising your blood pressure because you exercise? Absolutely not. In fact, the lecture on hypertension on YouTube that I give talks about how weightlifters lift these heavy barbells, and they lift them, their blood pressure go up to like 350 over 240. I think one guy's blood pressure was up to 480 in weightlifters lifting these barbells like that. and they don't break a single vessel. There's also a study in that lecture that you'll want to look up where they took cadaver arteries, in other words, out of people's brains, dead people, 10 of them, and they connected the arteries to a pump, and they closed off one end of the artery, and they used the pump to blow up the other end of the artery. They
Like a
had
balloon?
they had to raise the pressure to 1,780 millimeters. Let me say that again. 1,780 millimeters of mercury before any vessels broke. Sick vessels don't break, no matter what pressure you cause. You know, there's an experiment. I shouldn't talk about this because I know there are a lot of animal rights people, but it was in Germany during World War II. They did experiments on dogs where they cannulized the dog's arteries, and they raised their blood pressure like 3,000 millimeters of mercury. Then they autopsied the dogs. They found no broken vessels. Dogs died of something, heart failure or whatever. Healthy vessels don't break. So how do you make your vessels healthy? It's the food, not statins. It's the food. You know, the statins, the new shots that you get for cholesterol, all the drugs, they don't reduce your risk of dying of heart disease at all or much at all. Statins still, they hang on with a tiny bit of benefit. The rest of the stuff, no survival benefit. None. Why? Because the problem isn't the cholesterol. The problem is the food. The disease is the arteries. It's not the cholesterol. It's the arteries. They're rotten. And that's why when I tell you that prostate cancer is caused by the high-fat, high-meat diet, don't believe it. It's caused by the Western diet, which has so many other negative qualities. The prostate cancer, there's studies that show the relationship between developing prostate cancer and dairy, big, strong studies. Get rid of that stuff. In other words, the McDougall recommendations are very clear. It's a diet based on starch, like rice, corn, potatoes, beans, peas, and lentils, pastas, breads. That's what you say. How much percent of the diet is starch, Mary?
80%.
Oh, last time you said 70%.
I'm giving you a little bit more benefit.
You're giving me some more starch. One way I look at it, I say 90% because I just want you to eat starch until you can't eat it anymore, and then fill it in with a few fruits and vegetables. That's what I want you to eat. So you say you like potatoes. Oh, so does everybody else. How about sweet potatoes? Oh, yeah, they're good too. You like these things. Oh, meat? Let's see. Do I like meat? Do I like chicken? Do I like beef? Well, if you want to prove your love of these mussels, eat them. Oh, okay, you can cook it. You can boil it. You can boil the beef and chicken. Eat it. You won't do it. It's
No,
disgusting.
well, with nothing on it.
Yeah, if you put enough salt on it, or barbecue sauce, or steak sauce, then you can get it down. Otherwise, it's too disgusting. But you can actually eat a potato or a sweet potato or a bowl of rice and beans, especially if you put some nice chili peppers in it. So we say the same thing about the steak, right?
Yeah.
You cover it up with enough chili peppers, you get it down. But you get the point. It's not your diet. It's not that's why you're in trouble. It's the food. And it doesn't cost you anything to get it right. It saves you money. It saves you time, efforts. All right. Anyway.
Okay, so what would you say to this next question? Let's see. This is from Diana. She says, do you know anything about the lack of starch metabolism in some people? My doctor said some people can't metabolize starches and they have to bring their cholesterol down with a diet of meat and vegetables.
I've never heard that. There are certain types of sugars that on extremely rare occasions, like fewer than 1 in 5,000 people, maybe 1 in 10,000. There are a few situations where people develop an inability to digest certain oligosaccharides, which are sugars. I've never seen one. I bet most doctors have never seen such a case. The idea that you have to eat meat to lower your cholesterol. Hey, look, the results of the Atkins diet, the low-carb diets, the carnivore diets are clear when it comes to cholesterol. They raise bad cholesterol. They raise total cholesterol. Dr. Atkins, the big diet guru, dropped dead with heart disease. Yes, he did. He had horrible heart disease. I saw his angiograms.
Well, if you eat cholesterol, it would be really hard to get your cholesterol to come down.
That's what I would think. I don't know. It's really hard for people, and I know as much as I've studied it and lived it and so on. And sometimes when I see these low carbers step up to the plate and convince people that this is the way to go, even though extremely few people, like maybe one of them, and one of my, let's go maybe 1,006 billion people. I'm not going to go to the statistic. I'm going to lose you. But the point being is, all of human history is a history of people eating a diet based on starch. These weird diets like the carnivore, the Atkins, the low-carb diets, they're just a means to make you so sick that you stop eating so you lose some weight. And when you lose weight and you don't eat, then your cholesterol comes down. Then your blood pressure comes down. Then your blood sugar comes down. Just like if doctor put you on cancer chemotherapy. You get so sick you couldn't eat, and your weight would come down, and your blood pressure would come down, and your blood sugar would come down, and your cholesterol would come down because you weren't eating, because you were sick. That's how they work. And of course, the new Ozempic and Wegovy and Zaybound, I got that one memorized.
All right.
The new drugs out there, IGP-1 agonists, GLP, thank you, Mary, GLP-1 agonists. That's another. I have actually thought, I'm not going to call it the anti-Ozempic diet. I'll get into trouble. That somebody will sue me for copyright issues or trademark issues. So I'm not going to call the McDougall diet the anti-Ozempic diet. I'd like you to know it as the anti-GLP-1 agonist diet.
We have to think of a cute name for that.
You have to think of something, because you see, when you take these shots, it costs you $1,000 to $1,400 a month. Okay? What does it cost you to eat the McDougall diet? Nothing extra. In fact, you cut your food bill somewhere between 50 and 60%. Cut your medical bills, your drug bills, etc. With the GLP-1 agonist program, you lose weight until on average you reach 68 weeks, 1.4 years. Yeah, 68 weeks, 1.4 years. And then you stop. You reach a plateau. There's no plateau with our program. With the GLP-1 agonists, the way they work is by making you sick and not liking food. They talk about how this constant food hunger goes away. That's called an appetite. Okay, that's pleasurable, especially when you satisfy it, which you do with starches, vegetables, and fruits. The tongue is built that way. The whole digestive tract is built that way. You are a starchivore. You stop taking the shots and the pills, and you regain the lost weight. So you would think, as crazy as people are these days, spending $17,000 to lose 37 pounds, which takes 68 weeks, and they throw up and have diarrhea for the whole time, or at least some sentiment of those kinds of sickness.
Oh, most of them say they just feel great.
I don't hear that. Like that Carolyn Gale I told you from Honolulu.
Oh, yeah.
Okay.
Yeah, but the things I've read about the people that have lost weight just rave about, I feel so well. And
finally, they lost weight.
Yeah.
There's nauseated. They have vomiting, diarrhea. And also, they brag. They talk about these GLP-1 agonists. You're not going to mention their brand names anymore.
Okay.
We talk about these GLP agonists. You know, they brag. The scientists brag about the mechanism for it working is it delays gastric emptying. That means it delays emptying of your stomach. Guess what happens to foods that sit in your stomach for hours and days? They rot. And then what happens? You stink. You have horrible bad breath. So there's another big deal you get from the GLP-1 agonist diet. You get bad breath. Oh, I'm sure it goes on and
I
on.
call it the anti-glip diet.
Oh,
Well,
maybe one of our listeners can think of a good name. But we should,
Oh, I
if
think
people are
something.
crazy enough to buy into that garbage, they ought to be able to buy into potatoes and rice and corn. They're not, people aren't that, yes, they are.
yes, they are.
I'm not going to say it.
Some of them, not our viewers.
Not our audience.
That's
No.
right.
That's why they attend. Yeah.
Okay, next question. I know you're against colonoscopies for screening, but what would you tell someone that has found blood on a stool test?
Then it's no longer for screening. It's called a diagnostic colonoscopy. You really need to keep this clear in your mind. I say it every time, but I know you don't hear it. Screening is when you cast a net over a large number of healthy people. You come knocking on your door, on their door, and you say, "Sir, you need to get your PSA blood test done. Sir, I need to stick my finger up your butt and feel your prostate. Ma'am, you need to get a mammogram, or you need to check your breasts." That's screening. That's turning healthy people into patients. It's called disease mongering. If you have blood in your stool, you're not a healthy patient. Now you're in a situation where you've found a problem. It's not screening anymore. And now the doctor has to, some way or another, investigate what the source of bleeding is. So yeah, I would follow up with some type of exam. One of the studies I'm going to talk to you about next Sunday, I think we didn't talk about it yet, was how this a big national review. I've tried to explain to you folks that none of the studies on screening have shown to prolong survival, to reduce overall mortality. None. Breast, colon, prostate, except for doing a sigmoid exam. Why? It's because a sigmoid exam removes precancerous lesions without doing harm. The problem with a colonoscopy, it's like a 6-8 foot tube. They cause perforation in like 1 in 1,400 people, and 40 to 50% of these people die. So you got to save a lot of lives to make up for the ones you kill. So an 8-foot tube kills, a 2-foot tube does no harm at all. That's the sigmoid versus the colonoscopy. But the problem is you can't find a doctor who does a sigmoid.
Can't get one.
Yeah, they just don't do them. And they should. And the literature, I'll show you the article next Sunday. The literature review of screening technologies tells you exactly what I just said. These screening tests are too late. It's a 10-year-old disease by the time they even start looking for it. Whereas when it comes to polyps found by a sigmoid, they're precancerous and you do no harm. So you see some advantage, a survival benefit. So that's why the U.S. Preventive Services Task Force tells you can get stool for blood or stool for immunologic reasons like the Cologuard test. Or you can get a sigmoid exam or whatever. They think a colonoscopy is still the best, but it's not. It's dangerous. The only randomized controlled trial ever done on colonoscopy was published October 27th, 2022, in the New England Journal of Medicine, a 10-year randomized controlled study called the Nordic study, which is countries in Europe like Poland, Norway, which has a low incidence of colonoscopy. They don't recommend colonoscopy in Europe, nor do they recommend it in Canada to their citizens. First randomized controlled trial lasting 10 years. No survival benefit. The GI business is going nuts over this. They don't know what to say or what to do except to keep lying. And that's what they're doing. They keep lying. Because prior to this test that came out October 27th, 2022 in the New England Journal of Medicine, there were no studies that show any survival benefit from colonoscopy or even tested it.
But
With a
if
randomized
you
control.
find something wrong,
That's
then you
diagnostic.
have to, yeah,
Yeah, that's a different story.
completely different.
I think I made myself clearer. Yeah. Anyway, you're getting ripped off.
Thank you.
You know, it's just unbelievable what they're doing to you. But anyway, you think I'm exaggerating or I'm kidding you. I always present the references for you. They're in the slides I just gave you on prostate. I put a lot of work in to make sure you get the references. Look it up. You won't find facts that differ from what I say. You might find opinions, but those opinions are based on a lot of things, including economic welfare of the opinionator. I would say, I am the opinionator. I make a ton. I make $3,000 a pop every time you bend over and let me stick a colonoscopy up your butt. That's what they charge, $3,000 on average. Oh well. Stool for blood's only $3.
Okay, we've got a few minutes left, so I think I can fit in at least one, if not two questions. This is from C. They would like you to give a rough percentage that you recommend for weight loss of eating raw salads versus cooked starches and veggies.
All right, this goes back to the Maximum Weight Loss Program, which I published in '86, I think.
Yeah, so.
And it's still a national bestseller for Putnam Penguin Dutton. It's on their, I don't even think it's on their backlist. They still sell so many of them. Anyway, it's still selling. It's the McDougall program for maximum weight loss. And what it says is you should follow the basic McDougall diet. Almost everybody gets what they're looking for. Starches, vegetables, and fruits. If you're looking to lose weight, stay away from the nuts and seeds and avocados. Be real strict on the oil. All right, that's the general recommendation. 90% starch, 10% fruits and vegetables. When it comes to the maximum weight loss program, it drops down to, say, 70% starch and 30% or 25% green and yellow vegetables. And the maximum weight loss program is 50% non-starchy green and yellow vegetables and 50% starch. If you go further than that, you're not going to be satisfied.
But
You're not going to stick with the diet.
the question was about raw and cooked.
Oh, that was a question.
Yeah.
I like cooked food. That would have been simple for me to say. Well, cooked food has advantages in the sense that you can eat it. Have you ever tried brown rice or pinto beans? Pretty tough. Let's see, what other starches can you eat raw? Maybe potatoes. I don't think so. They're hard. I heard people do it. Maybe sweet potatoes.
Well, I think
She was
they're
asking more
probably-
about raw veggies. Like, do we need to be eating a ton of raw salads for weight loss, or does it not matter? I mean, some people think you've got to eat salads for weight loss. I'm not a
But I
big
don't think-
salad person, so
But I don't think, I think what the second part of the question that Mary asked was, I didn't answer it right as far as the amount of green and yellow vegetables. You asked me whether or not cooked versus raw.
No, well, do we need a lot of salads?
No. You should. If you don't like raw vegetables, there's a reason why. They taste bitter. I mean, think about it. Think about eating kale or broccoli or asparagus raw. It's bitter.
Well,
No.
we know some people who really love salads and they get platefuls of them. And even at our program, we
Used to-
used to see people
I hate that.
load up their plates with salads.
But Mary, they're missing the point of the program.
I know.
Because the program is designed to satisfy your hunger drive, to supply you with loads of energy. You need energy. You're not getting energy from cabbage. or broccoli or kale. There's hardly any calories in it. So you need to find a source of energy that allows you to look good, feel good, and function well. And that's starch. So should you eat it cooked or raw? Well, I prefer cooked because you can eat it. If cooking denatures it, makes it taste better.
Yeah, I think so.
I don't think there's any great advantage to raw. The idea that cooking destroys the enzymes, the food is dead, is a dead idea. It's not true. There's still loads of nutrients in cooked food. So don't buy into that nonsense. But if you like raw vegetables, fine. You might lose a little weight because they're less digestible. You will likely lose a little more weight. But I don't care how much weight you lose in a week or even a month or maybe even a year. I'm more interested in what you lost in 30 years, which, by the way, I heard from one of our people. I don't know whether she's listening tonight. Her name is Jean. You know, she's somebody that I met in Hawaii. Did you read this letter?
No.
Anyway,
I read that.
You read it. You're okay. Well, this is what makes me feel like I've done my job. When somebody says, "Hey, Dr. McDougall, I heard you 45 years ago talk at St. Helena Hospital in Honolulu. And I listened to you and it sounded reasonable. And I followed your program for the last 50 years. All my friends have disability stickers. They live in assisted living homes, the ones that are alive. I'm walking around having fun with the grandkids, just having a ball. I feel like I did my job as a doctor for that person. So I'm in for the long run. I'm not in for quick fixes, one-night stands. Go see the other doctors. Oh, by the way, we got to end, Heather, because I know it's getting late. But I want to give people an update, if you don't mind, on how we're doing with the program, the 12-day.
Sure.
How are we doing?
Oh, man. Well, we have a program starting on Friday, the 12th, and we are oversold. I mean, you always say we could fit in one or two, no chance this time. Oh, our next program's in March 9th. So
And I heard you had to add another program too. We won't talk about that, but I heard you did.
yeah. So we're
No,
taking
we
registration for the March
time.
9th program.
We may be becoming the fad of the day. I don't know. Ozempic is the fad of the day today, right?
Right.
So
Well, you're not going to use those
I'm not
words.
going to use that word, GLP-1. Anyway, it was nice talking to you guys. I'm glad the holidays are over so we can get back to work.
It was a great hour. Thank you, Mom and Dad, Dr. McDougall and Mary, for being here. And we will see you all this coming Sunday in just a few days on January 14th at 5 p.m. Pacific. And that will be our regular time, unless we're traveling or have some sort of schedule conflict. But usually we'll be there Sundays at 5 p.m. Pacific. So thank you all for tuning in on this special night. Thanks again, Mom and Dad, Dr. McDougall and Mary. And we will see you all on Sunday, January 14th at 5 p.m. Take
And
care.
remember, the truth don't change.
And it's the food.